we're going to talk a little bit about an echo that I had to report the other day. So this gentleman is, how old is he? He's born in 1958.
He's a middle-aged subcontinental gentleman.
Very nice. And I've got to report his echo. So we're just going to go through a couple of the images that we had on this guy. So first of all, let me just start with these images. We know that he'd had a heart attack. It was a non-STEMI or was it a STEMI?
It was a STEMI call.
STEMI call, excuse me. And I'm reporting this then the next day after his STEMI.
That's correct.
Okay, so first of all, when we're in our parasternal long axis view, here I've got my anteroseptal and infralateral walls. They seem okay. The LV is normal in size. Function, when we start to have maybe a bit of a closer look here at this this parasternal long axis view, maybe I'm getting a suggestion that this wall looks thicker than the other side of the wall. So maybe this isn't his first rodeo in terms of having maybe some hypertrophy, bit of a septal knuckle here. Yeah. And maybe this isn't thickening quite as well as it should do. So hypokinesis being less than 50% thickening as opposed to the infralateral wall here, which is maybe thickening more than 50%. Mm-hmm. I go to my short axis views as my backup view for any kind of regional wall motion abnormalities I see. I said that I thought that maybe the septum wasn't moving quite as well as the sort of lateral wall. It certainly looks a little bit thicker. That can happen when you've got hypertrophy. If we look at our mid-ventricle level now, we've got our anterolateral and posteromedial papillary muscles. Yep. The apex didn't look magic, did it, on the short axis?
It's a bit difficult to see on that one, so I definitely have another view to look at to see what's going on. Yeah.
So apical four-chamber view, we've got our anterolateral and infraseptal walls, and this is where I started to again think of you, because you were doing you did the procedure on him the day before, and this is what I want to talk to you about. Yeah. So the things that I guess are starting to worry me now is that this apex of the heart doesn't look normal, and we've got this sort of smoke coming through here. So tell me what you think about this when you see this.
So this is quite interesting because it also correlates with the ECG findings that this gentleman had. He had ST elevation, tombstone ST elevation in the anterolateral lead, so it's an anterior infarct. Yeah. And he also had some Q waves already on the ECG. So this infarct, happened maybe subacutely. So
okay. So as in quite a delayed presentation.
It was a delayed presentation. Nice, so looking at this echo, it's quite interesting. It correlates with the clinical findings and the ECG findings that, you've said that the apex was down and quite markedly down. The other thing that you mentioned also was that the septum was slightly thicker, and to me it looks a bit more echogenic. And this can also happen when there's a lot of edema and a lot of infarct. I'd be mindful of that. And so there's something that I'd be looking into as well. And so that might also fit in terms of the whole clinical picture. So the fact that he's already got some smoke, and that's spontaneous echo contrast that you're describing there, that I'm quite mindful that this didn't happen today. Or yesterday.
And this is basically that sign of maybe it's like really sluggish blood flow. It's almost like it's starting to form potentially a thrombus. Maybe it's a hypercoagulable state.
That's exactly right. This is a red blood cells sticking together, and it's a hypercoagulable state.
And any time that we see this sort of akinesis that we can see of the apex here, and particularly now that we can start to see this spontaneous echo contrast or SEC, we've got to be worried about thrombus, right?
100%, and especially.
And so this is why I think we need to start going to look in other views, off-axis views. Look at this one.
This is fascinating.
So there's a lot of echo contrast there. There's this structure here. We kind of lost that. Normal. The apex has that almost like triangular shape at the top, right?
Like conical shape.
Maybe a better way of saying.
And you can see the apex is really not coming in at all. Like it's not contracting at all. So. This gentleman has infarcted the apex, particularly in the anterior wall.
And then that's a worry, right? Then we've got this echogenic structure. It's almost like it's sort of got this square sign here, which is highly suggestive for a thrombus, right?
Yeah, I'd be very suspicious, but I can't put my money on it just yet. But I'd be very suspicious of it at the moment.
So what do you think we should do from here?
I think the next best thing to do is I'll get a contrast echo for this gentleman to really delineate that wall and to see whether this gentleman does have a apical thrombus.
We're going to look at it in multiple different views here. So here we've got our 4-chamber. We're going to have a look at it in our 2-chamber. 3-chamber, another nice view. Just trying to look at as many of the standard planes as possible, but then also try and have a look in some of the off-axis views. And I'm just trying to see here if we can start to have a look where we sometimes move
Here
the
a bit
focus
more.
up to the top.
Yeah.
We're trying to see if there's any of these off-axis images. We'll sometimes put lower colour flow scales over the area to try and see if we've, see if it's a real structure or see if there's sluggish blood flow.
Yeah, and it's sometimes people call it as the poor man's contrast. It really, it might give you some help, but you really need contrast echo.
Yeah, absolutely. You need contrast to do it. In the meantime, do you mind if I ask you to try and take me through the angio?
This is the left coronary system. You've got the catheter, which is called a TIG catheter that we use to make the initial diagnostic assessment. The left main comes across right at the beginning. On this view, you have the circumflex that comes down, and you've got a really you're looking for the LAD, but I can't see the LAD at the moment. Some people can see a bit of a nubbin, and we'll see it in a different view a bit more clearly. There is a lesion there, and this is probably a high intermediate or an IOM marginal branch, and there's probably another 70 to 80% stenosis there. And the LAD on this shot should really come down, and if you can see my mouse pointer, it should follow that track there, but
and that's obviously suggestive. 100% stenosis. You can't see anything in there, so LAD's gone.
100%. This LAD is blocked off right at the ostium. Where my mouse is where the origin of the LAD is coming across.
You kind of get
and it should just come around. This is, we just made sure the right coronary artery is flowing and it is nice, and there's nothing else that we should be worried about. And the way that I know that it's the right coronary artery, it's got a C shape. And you've got a bit of lesion there, so it's not completely normal, but there's no critical stenosis or obstruction that I'd be worried about. So we went ahead and tried to open up the LAD, and we've got a guide catheter in, and we've got 2 wires there already. So this is my wire there, but I'm a bit too far out. The actual LAD just comes up a bit more proximal to that.
And you can just see
a bit more nubbin there.
Yeah.
Now I've wired the LAD, and I've got a balloon to try and open up the artery. Now you can see the LAD come through. But it looks like someone's eaten away at the LAD, and that's all thrombus. Right,
wow, okay.
And remember that echo where the LAD supplies the apex. So I've trashed. I mean, this guy has thrashed the entire anterior wall with just thrombus.
And is that why we might be getting that edema you were talking about?
Yeah,
in that septal area?
Exactly right.
And
and
so it looks a bit thickened potentially from that.
Yeah. Interestingly, in this gentleman, he's got almost like a dual LAD system, where he's got a diagonal which also supplies a large area of the anterior and lateral wall. If I go fast forward a bit more, so this is me just ballooning up the lesions and just trying to open up and get rid of the clot as much as possible. And you can see a bit more flow down the LAD a bit more, but it's very sluggish flow, right? And this is microvascular dysfunction from just being obstructed from all the clot or thrombus down that we just showered downstream. So the LAD comes down just right down where my mouse is, and you've got a bit more lateral to that is a diagonal branch, and it also has thrombus and disease there. So at this point, he's already on therapeutic heparin. We've also started tirofiban in this gentleman. So we've got multiple wires in, and now remember before at the beginning pictures you couldn't see the LAD altogether. So now we've got the LAD flowing. Okay, so it's open, but we haven't done anything else at the moment, just balloon the areas. So we've now stented the proximal LAD right up to the ostium, and now you've got a bit more flow. Okay, so the LAD's got flow. The diagonal,
it's not sluggish anymore.
It's not sluggish anymore, but it's not perfect, right? But the other thing is you've got the mid to distal LAD it's almost like a string sign, and that LAD has tapered down altogether. It's still trash with all the thrombus that we showered downstream. Sometimes this LAD string sign you can see when they're in a catecholaminic response. So patients on high doses of inotropes, they get this string sign on the coronary arteries.
Oh, wouldn't that be interesting to look at in septic cardiomyopathy?
Yes, it'd be quite interesting to have a further look into it. So looking into that, you've got much better flow down the LAD there compared to what you had initially, right?
Yeah, great job.
And then these are the final pictures. We've taken the wires out. The stent is there in the proximal segment. You've got still a bit of disease there, but
yeah,
I mean,
you can see it where it's.
but the apex is not moving. So when you said, "Hang on, this guy's apex is not moving," it actually fits with the clinical picture of this guy.
Santhosh, thank you very, very much indeed for your time. That was really interesting. Cheers.
My pleasure.
Nice, thanks.